This cataract surgery deserves special mention for various reasons, and we will see that. Now, this is the eye for which the patient was concerned and approached the hospital for cataract surgery. However, as we can see, this seems like a shallow AC with posterior synechia and probably a complicated cataract. And this is the B scan, which shows an eye which has a nearly normal axial length, but we'll see that this is not normal for this patient, and this goes about 23.54 millimeters. As the media were not clear, B scan was mandatory and important, so this was done. And as we can see, the media in the posterior segment is not clear, and this eye had hypotony also. So this patient was counseled and was informed that this eye for which he was concerned didn't have any potential for vision, and the vision also was PL denied, which is an absolute contraindication for expecting any visual gain after surgery. This was the other eye which showed a similar kind of situation. There was a significant cataract. However, when on fundus evaluation, we saw that there was a pusticephaloma. And as we can see, this is the B scan, and which shows a very elongated eye at an axial length of 33.33 millimeters, which is extremely myopic and long eye with a pusticephaloma. So cataract surgery was advised for this eye, and patient was ready. However, the problem was that the IOL power which was calculated for emmetropia was 0 diopters. And because these patients who have been myopic for whole of their lives should not be left emmetropic at the end of the cataract surgery, so it was decided to implant a -1 diopter IOL power, which would provide the patient some myopia so that he will have comfortable near and intermediate vision, and for distant vision he may be using some glasses. So this IOL was not available in stock, it was ordered, and then when the IOL arrived, the surgery was planned. So the rest of the surgery is not very eventful, except that the anterior chamber in these eyes is very deep, and there is always a potential for degenerated vitreous and a zonular laxity, which can cause disturbance during the phacoemulsification. However, the concern is that should we be implanting an IOL power close to 0 diopters? So this is something which I would like to have comments upon in the comment section. And I have few takes which I would say, and I would advocate that we should be implanting IOL which are close to 0 diopters in all the eyes. The first plea is that if you want to have a targeted refraction at the end of the surgery and out as a visual outcome, then we have to have a IOL which will provide us with the targeted refractive status at the end of the surgery. And for that, there will be very few patients who will be fortunate enough to have a axial length which will provide them with a target refraction with aphakia. So for example, for a myopic patient, I would like him to be remaining myopic a little bit, something close to 1 to 1.5 diopter of myopia. And for that, if the patient has a IOL power coming out to be something like -1, then it may be for emmetropia, it may be good enough that at that moment we implant rather we don't implant a IOL, patient will be left behind with a myopia of -1, which may suit him. But otherwise we will have a situation where we will either need something +1, +2, or on the negative side. So this is one fact. If you desire to have an absolute bang on refraction of the target refractive error, then you will need an IOL. Second plea is that a notion goes on amongst the patient that they assume that cataract surgery involves not only removal of lens but also implantation of an IOL. And I have had situations where patients have in their simpler terms explained or expressed their understanding of the cataract surgery, something related to implanting a lens. So implanting a lens on an IOL is an extremely important step from the patient's point of view, and patients may not be happy and satisfied if they are told otherwise. So I think playing along with the psychology of the patients, there is no harm in implanting an IOL if the patient has a reservation that IOL implantation is a must step for cataract surgery. especially so if we want to target the emmetropia of the patient. One plea is, which is maybe debatable, is that the IOL provides a scaffold or a support to the posterior capsule so that the vitreous and the capsule doesn't bulge anteriorly, which may be an issue in these patients who have myopic, have degenerated vitreous, and also peripheral retinal degeneration, which may cause formation of retinal breaks with the anterior movement of the vitreous and iris lens diaphragm. So IOL, which is slightly rigid and provides that support, will prevent that from happening, and this may be a debatable point to see whether really it works or not. However, for me, I'll always like to implant an IOL in these eyes for various reasons which I have just mentioned. This surgery is not very challenging per se, although the nucleus was very hard, and we can see it needs, not only it's hard, it's bulky also. It needed multiple chops so that we have small fragments which can be emulsified without having any injury or insult to the corneal endothelium. Once we have chopped the nucleus into small pieces, we can go ahead, extract each piece out of the bag and emulsify it at the pupillary plane. This patient was technically only eyed on because the other eye was peeled in eye, so it was a concern not only for the patient but also one has to be very careful in these eyes so there is a good visual outcome without any possibility of any risk. Phaco under topical anesthesia is a good choice for these patients because they will gain immediate vision after the surgery, and any handicap will not be there if the patient is operated under topical anesthesia, in contrast to injection anesthesia where patient needs to be patched for few hours and maybe overnight. So this is a choice that these patients are operated under topical anesthesia so that they can have immediate visual rehabilitation, especially in a situation when they are only eyed. So as you can see, the nucleus has been removed, and now it is time to clean this cortex and then go ahead and implant the IOL. In the meanwhile, replenishing the anterior chamber with viscoelastic gel will always keep the endothelium well coated, and this will be obvious that it has helped when the cornea stays relatively clear. This patient also had apprehension and also had poor cooperation levels, so that is why the eye is all the time rolling up. That makes a little bit a challenging thing to do, but it can be managed with little coaxing and little dexterity of the surgical maneuvers. Engaging the cortex at the rexus border, pulling them to the center and aspirating them. In these patients who have high axial length, you would never want any rupture or damage to the posterior capsule, as would be true for any other case. However, it will be much more important to preserve the capsule in these cases. So if some amount of cortex which can be aspirated after implanting the IOL, that also may be a choice. There is a speck of cortex which is adhered to the posterior capsule which can be blasted away using the viscoelastic cannula, and the force of the gel coming out is one of the very safe maneuvers which can scrub this capsule off the cortex which is adhered, and some amount of subincisional cortex can always be taken care of. We can also see a PVD ring just behind the posterior capsule which can be seen as a round ring shape opacity floating in the vitreous, which can be seen as moving when the patient's eye is moving. This is a hydrophilic monofocal single piece IOL, and the problem is that hydrophobic IOLs are not so customizable as per the company's information, so we had to depend on this hydrophilic model of this IOL, and these IOLs as per the company policy can be made according to the desired power. So this is what was being used, and I hope it will provide the patient with target refraction as intended to leave him a little myopic. The IOL has been implanted in place, and now it is safe to remove the subincisional cortex. With the protection provided by the IOL, one can safely approach and remove the subincisional cortex without any risk to the posterior capsule. Cortex has been removed and now forming in the anterior chamber, so as the anterior chamber is sealed and the surgery has been done. This is the day 1 post-op picture showing the good outcome, and this is the fundus where we can see that the patient has chorioretinal degeneration involving the macula also. However, patient was happy enough because the kind of myopia patient had, now he was left with something like -1 diopter of myopia, which was good enough for his near work and also aided him in distant vision. Thank you.